Okay, perfect. So yeah, just a few housekeeping things. So attendees are not able to unmute themselves directly and ask questions, although we do have a Q&A option on the bottom for you all to ask questions towards the end of the event. We also have a list of questions that we prepared for our panelists, as well as a couple of questions that were sent over in the RSVP form, which we can ask time permitting as well. But without further ado, I'll just like to briefly introduce each of our panelists that are with us tonight. So we have Dr. Veronica Gonzalez, who graduated from DGSOM in 2023 and is currently a PGY1 EM resident at Harbor. Dr. Vivek Shah, who graduated from DGSOM in 2022 and is a PGY2 EM resident at Harbor. And then Dr. John Warren, who graduated from UCLA in 2020 and is a PGY4 EM resident at Harbor. So thank you all for taking the time to speak with all of us. First question to each of you, just tell us a little bit about yourselves and what got you interested in emergency medicine and what interested you in Harbor UCLA specifically.
Okay, I can start the ball rolling. I'm Veronica. I grew up in Gardena. I've lived in Torrance for the last like 10, 15 years, so very local to the area. I went to UCLA for undergrad, obviously UCLA for med school, so Bruin through and through. Um, I think one of the things that got me really into emergency medicine specifically was just having to go to the ER a lot with my family. Like that was sort of the quickest way to access medical care back then. Half of my family was medically uninsured, so just having that exposure made me really want to be in that area. And then later experiences through volunteering, through scribing in the ER, all of those things really led me to want to stay in the ER. I even started like med school thinking I was going to do EM at County. Like that was dead set on that from day one of med school. And so far, it's been everything and more. I really love my time in the ED when I get to be there intern year. Our intern year, we do have to rotate through different departments just so we have a well-rounded education. But yeah, when I'm in the ED, it's been great. And so far, intern year, it's been tough, but it's been really amazing, really really rewarding, I would say.
Hey guys, yeah, I'm also a SoCal native. I grew up in Azusa and then moved to Chino and then went to USC for undergrad and then decided that I'm going to do something better with my education. So went to UCLA for medical school and am now at Harbor. I think what really pulled me towards emergency medicine. So I went into medical school somehow thinking that I was going to do pediatrics because I loved my pediatrician. She was sort of like a point person for our entire family of just how to navigate the healthcare system, how to get care, regardless of if she was taking care of me, my mom, my dad. She was kind of like sort of this person that would demystify how to get healthcare in the US. And I think when I went to the ER after rotating through all the specialties during third year, I think the thing that really pulled me to the ED was that it was the one place that a patient could go to and hear the word yes all the time. You know, it's like if you have back pain, great, you're in the right spot. If you need housing, great, we're in the right spot. We have resources. If you're having a cardiac arrest, great, we're not going to ask you a question, but you're also in the right spot, you know? And so I think it felt to me that in a healthcare system that's becoming increasingly siloed with more and more barriers for care, the ED works as sometimes the only open door for a patient. And I think it really made me feel like a doctor to be able to say, sir, what is wrong with you? And sir, how can I help you? You know, and I think that even during hardships really pulls me through that sometimes this is the one place that patients can go to see a doctor. And I feel good being able for them to say, like, thank you, doctor, you've helped me out with this, you know? So
Yeah, that's an amazing answer. I grew up in Northern California, so wasn't a South Bay native at first, but started up in the Bay Area and grew up there, and then moved down for undergrad, where I went to for UCLA, and then continued my time at UCLA for medical school, and have essentially now been living here for like 12, 13 years, and maybe almost now a Southern California transplant. And we'll be here an additional 2 years afterwards. But I was pretty drawn to emergency medicine even before I went into undergrad and into medical school. I was very fortunate to have a father who worked for the fire service as not just a fireman and paramedic, but also was a member of one of the California task force teams. And for those who don't know, the task force teams are these developed teams of search and rescue physicians, firefighters, and other team members who will be deployed to natural and man-made disasters across the country so that they can provide support, medical care, search and rescue services to people. And so I basically grew up hearing these amazing stories from my dad of all of the emergency physicians that he actually got to work with, and just how awestruck he was by like their knowledge and their ability to be so calm, cool, and collected in the field. And then he started getting me more involved with the actual trainings, and he would bring me to some of the task force trainings. And I have like vivid memories being a 12-year-old kid getting like moulaged up with glass sticking out of my arm or a pipe out of my leg as one of the patients that they would have to come and treat. And that's really where my first exposure to emergency physicians were. And I similarly was awestruck, and like my path in life was set for me moving forward. Um, while I was in medical school, I did have some thoughts of going into internal medicine and really enjoyed my time there and kind of the complexity of cases, things like that. But I think what really stuck me through with emergency medicine was very similarly how service oriented it is. You really can be the end all be all for a lot of our patients, in that you can be there when they're worried about what's going on, or if they think that they're going to, have some life altering complication from whatever's bringing them in. You can be there to provide them resources. You can be that stability that's there in the community for them, where they may not necessarily get that from other aspects of the medical field. And all of that is really what drew me towards emergency medicine, plus the amazing things of I love thinking on my feet, constantly being busy and doing lots of procedures. So
That's awesome. Yeah, that's really inspiring to hear all of the reasons that inspired all of you to go into EM. You're all currently residents. Could you maybe speak a little bit to your day-to-day schedule as residents? I think you're all in different years. It'd be interesting to hear what your day-to-day is like.
So I'm an intern, which means our schedule at Harbor for EM intern specifically, we rotate every month or so onto a different service. So very similar to your preclinical year in med school, where you would go to a different, you would have your surgery rotation, your pediatric rotation, similar in that sense. But they try to make it tailored to what would be important as an emergency physician, like what skills and what knowledge would be important for us to have. So we do a month of OB-GYN, a month of orthopedic surgery, a month of trauma, things like that. I'm currently in the surgical intensive care unit for a month, and the typical schedule is you do like one day is a 12-hour shift, 6 to 6. The next day is a 26-hour shift, so you're on call. The rest of the day, whenever you get off, is called your post-call day, and then you have one day off. I'm currently on my day off. Tomorrow we'll go back for a 12-hour shift. The day after that, a 26, and so on. So it's nice that you have a lot of time off, but I will say most of my time on post-call is spent recuperating. And then the days off are finally when I get to do normal people things like this. So it's very nice. The type of things that you're seeing in the surgical ICU is very interesting, and I feel like especially if you're interested in emergency medicine, it's very up our alley with like the critical care component. I get to throw in some A-lines during my shifts there. We take all the admissions that come through the ED. Yeah, and lots of very sick patients, so it's really exciting for me anyway, like interesting. Yeah, and so that's sort of my day right now. I'm on my day off, so like I walked my dog, got my car fixed, got to do normal stuff, which is nice.
As a second year, you do fewer off services, much fewer. Most of your time is in the ER. So the off services that I would do would be an elective that I set up for myself, a research block for 2 weeks, and then a EMS pre-hospital rotation, which I think, side note, a lot of people who go into EM don't realize how much there is also in the pre-hospital sphere. And like, I think no other medical specialty really at all gets to touch on the complexity and systems and medical management of pre-hospital care. So I'll leave that for our EMS fellow, Dr. Warren, later. But a day-to-day for PGY2, it all depends on your shift schedules. And I think the biggest elephant in the room is like, as an ER physician, are you just jumping back and forth from shifts and shifts? And not necessarily. It's more of a gradual transition from different types of shifts. So there's three types of shifts. There's a day shift, which is usually 7 a.m. to 5 p.m., 6 p.m.-ish. Then there's a swing shift, which is from around 3 to 4 p.m. to around 1 to 2 a.m. And then there's a night shift, which is from 12 a.m. to 8 or 9 a.m. the next day. And so what usually happens is you'll start on a string of days and then go to some swing shifts and then go to some night shifts and then kind of slowly go back up that way. So I'm actually post-night, which means yesterday I worked from 12:30 a.m. to 8 a.m., slept until around like 3 o'clock today, woke up doing my regular day. I essentially get half an entire day until I go back to work again. And I think that's something that you have to go into EM being okay with, that you are going to work odd hours, and that your shifts will be switching like that. So if you're someone who's like, absolutely not, I only do days and I will do nights if I'm forced to, that's going to be tough. But I think it is, in the end, as John mentioned, when you are on shift, your day-to-day is you clock in and you just start working. Like, there's not a lot of downtime, like some inpatient rotations where you round, see patients, sit and write your notes. No, it's like you put your backpack down, you've told everyone you are ready, and then the day starts. But the beauty is that the day ends at a very definitive time, and when you're off, you're truly off. And so what I do during like my off time, let's say it's a day shift, I'll come home, I'll go exercise, make dinner, go to bed, and essentially have a 7 to 5 regular job, wake up the next day, go to work. On a swing shift, come home, wake up around, instead of 7 a.m., 10 a.m., go gym, eat lunch, go to work, do the same thing. On a night shift, you kind of just like, you push your activities of daily living to different times of the day. And so I think it's totally doable, but just come in knowing that you're going to work some odd shifts here and there.
Yeah, I think Vivek put our schedule essentially the best. As a fourth year, we have a slightly lighter schedule in the number of shifts that we're going to end up working per month, but we still work on that same like circadian schedule. So we'll work a few day shifts, we'll work a few swing shifts, we'll work a few night shifts, and then it'll give you some time off where you switch back to the beginning of that and you go day, swing, night through another round of shifts. And it works great. You have a fair amount of time. I do really appreciate that, the fact that when you are on shift, it is very busy and you don't get bored because you're constantly seeing people. But then when you're off shift, you actually have that time to relax and spend time pouring yourself into the hobbies and the passions that you actually enjoy outside of medicine, because we're all different people with varying interests, and it's nice to be able to continue those while you're actually in residency and your career in the future as well. Things that change in fourth year is we have a fair amount of more time for selectives and electives, which Harbor uses those names for what they are, but essentially they are rotations we designed for ourselves. So you can either do it in specialties where you want to get more practice. If you don't feel as comfortable with like dermatology, say, you can go do rotations in clinics within dermatology or ophthalmology, or you can use it to build out research blocks for yourself, get better in certain areas of emergency medicine. One thing that surprised me when I got into emergency medicine was just how much there is that you can branch into within the specialty itself. And so there's a large number of fellowships available to those in emergency medicine, and those selectives kind of provide us that opportunity to really start and explore them. And so I can definitely speak to ultrasound and to EMS. I'll be doing both of those fellowships starting next year, but there's a multitude of other options from pain management to regional anesthesia to critical care. Pretty much anything you can imagine. There's been a lot of emergency physicians who have started to go into it, which is pretty amazing.
Yeah, and sorry, just to piggyback off what John said about the ability to kind of do your life outside of the hospital, I think, something I would really consider when you guys are picking your specialty is what type of lifestyle balance you have. Like some people truly get a lot of fulfillment from their work, right? And some people need fulfillment from other areas. And I think really being honest with yourself about that. And so I think emergency medicine is one of those very portable types of careers where, let's say in the future, you have a family and are working, your kids are younger and you're like, I can't work as many shifts as I used to work when I didn't have young kids. You can scale down your number of shifts. You can move them to nights. You can move them to, weekend blocks. You can help drop your kids off during the weekdays. And then let's say your kids then go to college and now you're an empty nester. You can go crazy and just do all the shifts you want, right? And so it's really easy to kind of flex and shrink and grow and move your practice around. You can pick up shifts at different hospitals. You can move around. Some people go to different states where they are going to vacation and then do a few shifts before they start their vacation and then vacation. So very, very portable in that way.
It's very, very well put in terms of thinking about, getting fulfillment both from your job as well as exploring other passions that are really interesting and important to you and kind of negotiating that for yourself. And I think that kind of transitions on to our next question, which is post-residency, how do each of you envision your practice, private practice versus academia, county hospitals versus private hospitals? Like, how do you envision your practice after finishing residency?
I think it's really early for me to start thinking of, I mean, I should probably start thinking about it and I have an idea of what I would like it to look like. Um, I think something that I actually really took away from UCLA was I think it's Dean Braddock who says like being a physician and I don't know who says it, but it's definitely a UCLA thing. And so I always thought about what I wanted to do like future wise, like that it would definitely involve being a physician and something else. I think for right now, I have loose interests in things, and I don't know how that will take shape in the future, but I really like teaching. I think that's really interesting. So maybe doing like ultrasound stuff at the med school level would be really cool. Doing some sim stuff, like simulation cases. Yeah, I don't know, what I want to do specifically, but I think definitely still working as an EM physician, hopefully at county, because I think county is really something special, like a very special place. But then also doing something within the realms of teaching.
I'm planning on doing a critical care fellowship after residency, and so splitting my time between ICU care, and then depending on where I end up working, and kind of the beauty of EM is working at a bunch of different hospitals. So I think early on, maybe doing a few shifts out in the community while also doing ICU shifts. And then I think county still has a very special place in my heart. And so a lot of our grads also, they work elsewhere and they'll come back and do 2 to 3 shifts per month at Harbor because they love giving back to the specialty and love teaching. So I think that is definitely something that I would like to do. And then I think overall, I'm also interested in teaching and education. And so trying to blend that in. So maybe working at like an academic institution for ICU, doing some ER shifts here, doing some ER shifts there, and kind of blending it together however I fit. And that can change over the time, which is, again, the beauty of this profession. And I think kind of just going off on the ideas of fellowship, like John mentioned, there are a lot of different types of fellowships, ICU being one of them. Probably the one that I've looked the most into because I'm personally interested. And so the way to think about it is that you can be an ICU doctor from a lot of different specialties. and you bring to your ICU training what you learned in your base specialty. So from medicine, you can do pulm crit care, right? And so you become a pulmonologist and you work in a medical ICU. From anesthesiology, you do ICU and you work sort of in your cardiothoracic ICUs, surgical ICUs, sometimes neuro ICUs. And then EM has the ability to kind of work in any of those, right? Like you do your ICU training, but since you have such a broad base from the beginning, you can work in a medical ICU, you can work in a surgical ICU, you can work in a CT ICU, you can work in a neuro ICU. And on the other end of the spectrum is surgery, who usually primarily sticks to surgical ICUs. And so that's just kind of a thought process of like, you know, if you're really considering critical care from the beginning, trying to think of what pathway you want to get to there. And I would say personally, I think EM is probably one of the best pathways, but I am probably a little biased. But yeah, I think that's how I want to split my time in the future.
I feel like we're all going to be very biased towards emergency medicine in this entire panel because I think all three of us absolutely love it. Um, I recently have been doing a lot of thinking of what I want my future career to be like because in what, 4 months, I'm going to be graduated and actually having to step into that. And so in the next 2 years, what I'll be doing is actually this combined ultrasound and EMS fellowship. And my thought behind it is I would very much like to see and explore and bring ultrasound into the pre-hospital field. And so there's a number of indications where patients are being seen before they even get to the hospital, where ultrasound can answer some very time-sensitive questions of just like yes, no things that would allow paramedics to start to intervene and really support and start treating these patients even before they get to a point where we see them in the emergency department. And there's not much research that has really addressed that other than showing you can teach paramedics how to do ultrasound. There's nothing actually showing clinical changes just yet. And so I'm hoping to do these fellowships and really set myself up for success to build that out and actually start to do some of this research. And so with all of that and with what my passions are, I've been looking more towards aligning myself with more of like an academic career in emergency medicine, something that is more working shifts with residents, providing teaching education to medical students as well. In this role, I would certainly be designing curriculums and preparing things for paramedics and doing education for them. What's nice is with both of these fellowships, if that portion ends up not, building out, or for whatever reason I'm unable to go into it, I can shift my focus and use my ultrasound fellowship to become an ultrasound director for a hospital where I lead and create what their QA processes are and how they start to bill and prepare and do ultrasounds in the emergency department and throughout the hospital. Or I can shift and become a medical director for a county or city where I am creating the policies and procedures for their EMS providers and how we best take care of patients before they reach the hospital. So what's nice is doing these two fellowships will open me up to both academic and community options. And what's nice is with emergency medicine, and like Vivek has been saying, you can shift between the two. And so if I end up doing one and really just for whatever reason, absolutely not enjoying it, I can start to shift my career in the other direction as well, having that background of both emergency medicine or these fellowships to build off of. And I think it's important. It's not important when you're choosing the specialty, but once you're in emergency medicine, starting to think about what type of a career you want to have in the future, because like Vivek was saying, you can be a very amazing community doctor who's serving the community and doing amazing medicine and caring for them. And you can still work moonlighting shifts at an academic facility if you feel like you are very engaged or attached to education and you want to make sure that that still stays part of your career. There's some very certain very fine lines that happen with certain organizations if you start to work with them and what the opportunities are, but that's like very nitty gritty once you're being hired as an attending type things to worry about. That is what all of my class has been talking about and why it's on my mind right now.
Awesome. Thank you so much, everyone, for really showing us a bunch of different, pretty distinct avenues we can take from EM. I feel like everyone really appreciates hearing that. Now, for the next question, we were hoping to kind of get your thoughts on what you think the role of, EM physicians is in addressing healthcare disparities and advancing, equity.
I think you will get very robust answers from all of us because we're all very passionate about this, especially as EM residents at Harbor, where our patient population is one of the most disadvantaged population. We serve primarily like SPA 6 residents, so LA County is divided into specific service planning areas because it's so large. And service planning area 6 is one that has historically lots of health disparities and difficulty in accessing medical care. And so with that in mind, a lot of our patients are underinsured, uninsured. We have homeless patients, patients with poor health literacy. You name it, we'll see them and we have them, and we care very passionately about our patients. And honestly, that's one of the main reasons, or one of the biggest reasons why I was so drawn to EM. It's, as Vivek alluded to previously, we're the ones who will not say no to you, regardless of whatever, insurance or, legal status you have in this country. And I think it's definitely a passion of mine, and the reason why I love EM so much is that you get to engage with all of these people, and oftentimes we will be the only providers they will ever see in their lifetime. We're oftentimes the first doctor they've ever seen, when they've been pushing back all their health concerns all of these years, and finally they come in with that massive MI, with that large stroke. We're the ones who are engaging with them, and the way that we engage our patient population will really shape the rest of their engagement with the medical care. If they receive awful treatment, if they feel that they're being perceived in a negative light, what's the likelihood of them ever going back and seeing a physician again for their follow-up appointment? So I'll just start the ball rolling with that, and I'll let everyone else answer. But yeah, I think it's a very important part of what we do. And I think if you're going to go into EM, it's something you should definitely consider, that part will play a large role in what you're doing in your day-to-day life. I almost feel like you have to want to address those concerns as an EM physician, or else you might be bogged down by the system. You'll get very frustrated very quickly if that's not an interest of yours. But yeah, I think it's definitely something very important that we do as EM physicians.
Yeah, I read this question yesterday when you guys sent it out, and I've been thinking about it since, especially on my night shift last. And I think, what is the role of emergency medicine in addressing social determinants of health? And I think at this point, it is probably one of the biggest factors in our entire career. And I think, be honest with yourself if you're thinking of this specialty. If caring for under-resourced patients or caring for disadvantaged patients is not something that is of interest to you or something that would frustrate you, this probably is not the specialty for you, because it is a cornerstone of what we do. It is something that we are very proud of what we do. And I think from the very beginning of the conception of emergency medicine, it was the entire ethos of why the specialty was built. You have a lot of different specialties that are built around specific disease pathologies, different presentations, and EM's entire ethos was, we are built around providing patients access to care when they need it. Full stop, end of story, right? And so knowing that is what you are getting yourself into means that you do have to face all the frustrations and sort of slow decline and collapse of the healthcare system every single day, and being there for your patients every single day for that. And so, it is a tough part of the job. And I think it is sometimes what leads to the most amount of burnout in our field, because we go into it knowing that this is what we really want to do, and we have to bear witness to sometimes the worst of humanity, and be there for our patients. And I think that is an incredibly gratifying part of the specialty, and also an incredibly fulfilling part, but at the same time, on a day-to-day shift basis, can also be a very tough part. And so sort of specific things that we do to address health disparities is, when patients come in and they're unhoused, they're immediately flagged as unhoused. And we do our entire medical care in parallel with working with our social worker to make sure that they're getting resources for housing. How can we make sure that this person who has a stroke, is unable to walk, can go to a recuperative care facility? When, the dentist won't accept that patient's insurance and they say, go to the ER, we become dentist. I'm draining periapical abscesses. I'm sending people to dental clinics. I'm figuring out how they're going to get their follow-up. When patients can't see their primary care provider for 6 months out because primary care is also doing their best in trying to support this massive wave of underinsured and uninsured patients, we are there when their chronic illnesses have acute exacerbations. And we are also there to manage sometimes their chronic illnesses. I have diagnosed cancer and diabetes in the ED more often than I should, but it also means that I am there to advocate for my patients. And we have set up expedited workup clinics where if you are uninsured or underinsured and you have cancer, we will set up a clinic appointment so that you can get your follow-up, you can get your biopsy, you can start treatment. The first patient of my intern year was someone who their cancer facility in Arizona shut down and they said, sorry, goodbye. And he was in between his treatments. And so he knew that there's only one place to go. And so he came to Harbor and, he wasn't having an emergency, but this man, if he did not get treatment, would have severe complications of his cancer. And so I called up hematology, I made up appointments, I got him on Medi-Cal, I spoke with family about transportation, we got him into his clinics, and he's receiving his treatment. And I think, if you are coming into EM for just the sort of sexy critical care resuscitations, it is a big part of your job, but it's not the entire thing. And most of the time, and a lot of the time, you'll be spending a lot of time doing this for the patients.
Yeah, you're going to get some very biased answers. All three of us are from Harbor, which is a county facility, and all three of us are exceptionally dedicated to our patient population and who we're serving. And that's why we came into emergency medicine, and the same with all of our residents. And so Harbor is an amazingly special place in that it is a county facility, but it is exceptionally well resourced, which is why we are able to have these expedited workup clinics, why we have language services available 24/7 in the emergency department for translation, why we have social workers who can help connect people to care, substance use resources, things along those lines, and why we're also passionate about addressing these inequalities and kind of advancing healthcare from this manner. But it's also something that is present to a degree through all of emergency medicine. And I think I've really noticed that in the last 5.5, 6 years. I remember as I was applying for residencies and kind of interviewing at different residencies back when we still flew out and would go see places and talk to them, that was when, there was a huge opioid epidemic and people were going through opioid withdrawals, or they were going off to go find heroin, or they're starting to use fentanyl, things along these lines. And they couldn't find the support they needed within the primary care system because there really wasn't built out measures and there wasn't medication that people were familiar with. And so emergency medicine said, well, we are seeing all these people, they come to us, let's take that role. And now buprenorphine clinics have become larger and more prominent throughout EDs, that we've been able to refer people to care and really get them the support that they need for opioid use disorders. And now we're seeing the same thing start to happen with alcohol use disorder, something that, a lot of people are trying to get help with. It is exceptionally hard to stop and can't always be addressed in primary care because primary care clinics are constantly overwhelmed, but that we see frequently because people are coming in either for intoxication or for their withdrawal symptoms or for some result of their intoxication that may have brought them to the emergency department. And again, emergency medicine has very much started to adopt that. Well, if no one else is going to be tackling this, then that's going to be our role as well. And so you're seeing these emergency medicine providers where they didn't necessarily previously have skill sets starting to become far more comfortable with not just managing alcohol withdrawal, but how do we curb those cravings? What medications can we use? What resources can we really start to plug them into that are actually evidence-based and useful? And how do we start to address it? And then you get to COVID, and suddenly everyone was sick, everyone was closed down, and all of our patients are still coming to the emergency department, and ICUs are full, hospitals are full. And again, emergency medicine was like, well, let's take this and we'll start to address it. And so we were running an ICU out of our harbor emergency department for a period of time where we were taking care of these patients where it was too full upstairs and we had to watch them for a period of time. And I think that very much is the emergency medicine personality. You want to go that extra step so that you can take care of the patients. You're willing to learn more, you're willing to do more. And while you may not know all of the very exact specific methods of care, we're amazing at learning the first 5 to 10 steps of managing something so that we can get them stabilized and onto the care that they need moving forward. And I think that mentality has really gone into the specialty as a whole, addressing healthcare disparities, things like that.
Great, thank you all for speaking to this such an important issue, and it's really nice and great to see for everybody how passionate you are and really representing the field. We also had some questions come in from people who signed up beforehand, and one of them that I think would be really helpful for maybe our MS3s hearing this would be, your advice for sub-Is. Like, how did you approach it? What did you want to tell yourself kind of going through it again, and overarching advice, as we all are used to this sub-I, yeah.
Harbor actually has a bootcamp web series coming up about how to prepare for your sub-Is. So log on to Instagram and follow us there, and you'll get linked to our upcoming webinars on how to prepare. I think overall, though, is since I kind of just went through this about a year ago, I think really setting yourself up for the sub-Is by choosing your resources is going to be really important. There's going to be so much, information out there, resources, advice from several of us, several of your friends. So I think honestly, paring it down and choosing a few resources, following a few sets of advice is going to be important so that you're not feeling as overwhelmed and you don't feel like you have to listen to 100 different podcasts and, watch all the videos. And really focusing it down to things that you feel are relevant to yourself, as well as deciding or going through the biggest like high yield thing. So you're gonna get a belly pain in the ER, you're gonna get a chest painer, you're gonna have someone with a headache, someone with dizziness. So I think choosing a few of those big topics, going through reviewing differentials, I think that's going to be really important. And I mean, that's like the bread and butter for us, those topics, and just going through differentials. I mean, you will get a person and you're not sure what's going on with them, going through system space, like what could it be related to neuro? What could it be related to infection? I think that's going to be really important, and that's sort of more like academic-y things to prepare. I think otherwise just coming in with a great attitude is going to be really important, showing that you're passionate about the field, showing that you're interested, volunteering to do the laceration repair, all those things will really set you up to be a good sub-I.
Yeah, I echo that, is that there are so many resources because EM has been one of the forefronts in free online medical education. And so I think we have done something where we have just created so much free online medical education that's sometimes tough to figure out what works for you. And so I think before your sub-I, pick 2, maybe 3 resources where you're like, this is where I'm going to get my information from. And then the next step is just what Veronica said, is that go through all the big chief complaints, because the way emergency medicine thinks is sort of the way that you would do your OSCE, which is, what is the chief complaint? What is the patient coming in with? What questions on my history do I have to ask? What things do I absolutely have to figure out that it is not? And I think that is something that sometimes trips some people up, because you're taught in this mode of medicine where you have to figure out what it is. And in the ER, you do not have the time, nor the resources, nor the testing capability, nor sometimes time frame in disease to figure out what something is. And so you need to work backwards in that you need to figure out, what is this not? This is not a heart attack. This is not a pulmonary embolism. This is not bleeding in their belly, etc. Right? So you need to figure out what it's not. And then when you figure out what it's not, I think another step up sometimes for sub-Is, and I would try this maybe on your later shifts, is to think about, what is the next step for this patient, right? Where are they going to go? And if you're going to discharge them home, great. But also think, what is their follow-up going to be? What do you want them to ask their doctor, right? If you have someone with a headache, them coming in and you're like, okay, this is a migraine. It's not a subarachnoid hemorrhage. I want you to go home. I want you to talk to your primary care provider, and I want you to ask them about your migraine symptoms. All right. These are certain medications that they could start. When would you send them to a neurologist? Right. And so that is sort of like the next level of like, what is that patient's disposition, which is sort of where they're going to go and why are they going to go there? And also ask yourself, what would you like that provider to do for that patient? I think that's sort of how to prepare for any specific sub-I. Now, how to prepare for where to do your sub-Is is a whole other bag of worms. And I think John and I both had the maybe luxury of not being able to have a choice, because we were sort of COVID babies in which you could only do 2 sub-Is, and great, UCLA has 2 sub-Is, end of story, right? But I think now that we're kind of going back to normal, I'd say do, of course, the 2 home institution sub-Is. They are fantastic and very different also, right? So you get a huge breadth of emergency medicine. And then think of another place in the country that you would like to live that has a reputable, good, well-established sub-I program, and rotate there and send out a few different options. That way you have options of where you want to do your your away rotations.
Yeah, I agree with everything they said. I don't know if there's really too much more for me to add. I think piggybacking on both, online, you can find those lists of like what are the 10 most common complaints in emergency medicine, and I would get familiar with those. And we always think of like, what are the main diagnoses that we want to rule out, like Vivek was saying, and being familiar with those is going to be important. And there's a number of resources online. Sometimes it can be hard to pare them down. Ones that I've really found and loved, I have no disclaimers. I'm not sponsored by anyone. It's all free online medical education. But EM Docs is a really wonderful website. They have a series called EM at 3 a.m., which is like very short, concise summaries of different disease processes. DDX of is really wonderful. If you are having some trouble with your differentials, you can just type in red eye and it'll bring you up like a nice chart of how to evaluate and what the differential for those will be. And both were very helpful websites, both preparing for a sub-I and while I was on a sub-I, because you can just quickly go online and reference. The last one would be WikiM, which again provides like very concise, short summaries that you can use both in preparation and for your sub-Is themselves. In addition to the choosing sub-Is advice and everything else that was already mentioned, the only other thing I will say is that when you're on your sub-I rotations, one thing that really helped me 4 years ago, and what hopefully has helped others as I've shared the advice, is after each shift you finish, choose one of the patients, choose whatever that chief complaint was, and spend 15 to 30 minutes at most just sitting down and reviewing it, because in the emergency department, you continue to see everything. So if you saw one rash, you might not see it tomorrow or the day after, but for your 5th shift, you may end up seeing another rash, and having that spaced repetition of reviewing all of it is going to be really important and help build your knowledge base.
All right, sorry guys to interrupt, but I'm gonna have to head out. It has been very fun sharing why I love EM. I've shared my number with the coordinator, so if you guys have any more questions, feel free to reach out, okay? Take care, have a good day.
Thank you so much.
I will
Alrighty, that
say,
was
sorry, just as before we go any further, one thing that I have been thinking about as we've been talking, we all very much love emergency medicine for all the reasons that we've been saying, but also a lot of what we love about emergency medicine ends up leading to a fair amount of burnout within the specialty as well. And I'm sure a lot of you have heard how burnout is absolutely rampant across medicine right now, but that in particular, emergency medicine has been quite affected because of long waiting room times, more administrative tasks, not being able to get the appropriate care that we want to get for our patients, things along those lines. And having that advocacy, while it's really wonderful and what we're all very passionate for, does lead to some burnout amongst the specialty. And so I just want to be fully open and realize that that is something that all of emergency medicine is dealing with. But I feel like it also self-selects for those who are very passionate and willing to work forward and continue to address these things.
Thank you so much. It was great for overall throughout medicine and also in EM. But also that was great sub advice. I feel like for everybody, like a lot of that also applies to internal medicine, I think. So that was great. Thank you so much. And then we also have in addition to medical students, we also have some pre-meds on this event. So for them, kind of whether they're getting really interested about medicine because they're interested in EM or just considering EM, it's earlier on for them. What sorts of advice do you have for them in terms of how to explore it and go about deciding on
things? Sorry, how to go about deciding how to go into?
Yeah, how to go about deciding whether or not they actually EM is the best fit for them, whether as pre-meds or as medical students later on.
Gotcha. I think getting exposure is going to be the most helpful. We obviously have already talked about personality wise, like what kind of person would be best suited to be in EM. But in addition to that, like actually getting some experience, whether you're in a clinic, like in the ER, volunteering, there's lots of great volunteer programs out there. I will say I did a scribe in the ER, and I think that really solidified it for me. Just being able to be there with the doctors, going room to room, seeing different patients and different pathology really solidified for me, like that emergency medicine was going to be the field for me. And then throughout med school, just being involved in different organizations. I did a lot of ultrasound, like rotation or ultrasound, like adjacent activities, being involved with your local EM group and doing clinical rotations out like outside of your whatever framework. I think that also really solidified for me that emergency medicine was going to be something that was of importance to me.
Yeah, I agree. And I think if you're in the pre-med space where you don't have access to clinical rotations just yet because you're not in medical school, there's still a number of things you can do. Like Veronica mentioned, you can try scribing. Obviously, that can involve getting a job and actually trained, things like that. And sometimes people's schedules aren't amenable to that. But a lot of places will have the ability to go and shadow. And so even if you reach out and start making connections with attendings in the emergency department at Ronald Reagan or with us at Harbor, I'm sure they are more than happy to have you shadow them so you can come onto shift and really experience what it's like as an emergency medicine physician. I'm not familiar anymore because it's been about 8 years since I was an undergrad, but UCLA did have a couple of like pre-med societies and groups that would help to coordinate that shadowing as well. Because I remember as a medical student on rotations, having some of them join me in the emergency department as well. And so I would really use those and leverage the contacts that are there and created within the UCLA or whatever campus you may be at, their system to get the exposure and really see if it's something that is right for you.
Yeah, I think that's definitely really helpful. We are close to the end here. Just out of respect for everyone's time, we have just one question from an anonymous attendee about being an EMT for getting exposure to emergency medicine. I think, John, you're already about to answer that, but maybe if you want to answer it live.
Yeah, I can answer live. It's It's great exposure. I think you'll really get to see pre-hospital care and care in the emergency department can be very different, but both are very similar in that you are starting to address and answer these questions with very limited information and treating patients with just the information you have in front of you. So I think being an EMT gets you great exposure for emergency medicine and what the thought process is like. Sometimes it can be a little bit different in that it doesn't go as in depth into thinking about what the diagnoses and what the treatment and management are, just because what you have available in the pre-hospital space is relatively limited, and it doesn't always address all of those social aspects. I mean, there are programs in areas where EMTs are and paramedics are starting to provide primary care in areas where it's definitely very short and needed. That isn't happening here in LA County just yet, to my knowledge, but that it is a good marker, but it isn't the full experience of emergency medicine, I would say. And so if you have the opportunity to actually go into an emergency department, I would.
And then we have just one more question. I think that'll be our last question, is what changes administratively in the structure of emergency medicine would you like to see to improve the physician and patient experience?
I think there are a number of things that can be addressed, and I don't know if it's necessarily things that can be addressed on a hospital basis, but I think it needs to be more on a government wide and how we provide healthcare here in America, which ends up being a much larger discussion than just the structure of EM and affects multiple other things. But I think one thing that is very difficult about our specialty is you have all of these patients coming seeking help, and you have such limited resources. And so, if you had access to more resources, whether that be more rooms in the emergency department, more physicians that you can hire, more nurses to staff the rooms that you now have available, then you would actually be able to sit and address and see everyone who's coming in. But as it is with the burnout that people are experiencing with administrative tasking, such not that nursing ratios are bad, but such as nursing ratios, and other things that need to be done for each patient that comes in between registration, checking insurance, things along those lines. It ends up leading to this backlog and why we're starting to get waiting rooms that are 70 to 80 people deep at all of our emergency departments within LA County. That I think, honestly, if you had more funding, more money, more availability to hire clinicians and providers, that it would help address a lot of that backlog. But that ends up becoming a more government level discussion rather than administration at hospitals.
Yeah, I will say like it's kind of tough to isolate EM and fix things within EM because we get so much like a lot of these changes out everywhere else, we will feel the effects of it. So it's sometimes out of our control. Like just one thing that John mentioned, like having boarding in the ED. Sometimes we're holding on to so many really sick patients that are admitted, need ICU beds, need, whatever type of bed. And the hospital just doesn't have that bed available. So we're holding on to them in the ED. And then that means we can't see as many patients. That means they wait out in the lobby much longer before they see us. So some of the stuff that John mentioned definitely could help with that, but I think medicine is such a interconnected thing that isolating EM and trying to fix it within EM is going to be really tough because we're so affected by everything else around us.
I think that's definitely very insightful in terms of the level of systemic change that we need to improve both the patient and the physician experience in EM and across other specialties in medicine as well. We are on the dot at 6. John or Veronica, is there anything else that you'd like to say to our attendees before we conclude?
I just said emergency medicine is a great field. Obviously, we are very passionate about it. And if anything that we said during this talk struck a bell with you and is something that piqued your interest, definitely look into shadowing EM physicians, working, doing rotations in an emergency department. And definitely reach out to us if you guys have any questions and, along your journey, whether it's related to emergency medicine or not. There's a lot of different specialties that have overlapping, interests. So, like John mentioned, he wanted to do internal medicine, probably because he gets to see a lot of different pathology, and that's exactly what happens in the ER. We get to see so much different pathology. So, if you guys decide EM isn't for you, but you're still, looking for someone to help guide you with medical school application, the sub-I experience, things like that, definitely reach out to us, and I'm sure we're more than happy to help.
Yeah, I would echo the same. For the faults that we do talk about with emergency medicine, there are so many more advantages and amazing things that you can do within it, and why we are so passionate and biased towards this specialty and why we love it absolutely so much. And happy to be here as a resource for any of you, whether you're going into emergency medicine or into any other specialty. I'll make sure that all of the hosts here have my contact information for both my phone number and my email. I'm constantly available, even if it's at like 2 a.m., because I might be working a night shift that night anyway. So feel free to reach out and I will eventually respond if I'm sleeping the next day.
That's very kind. Well, thank you so much to everyone for attending our event, and thank you especially to our panelists for sharing their personal journey towards emergency medicine, as well as their insights into the specialty and what their plans are afterwards. We will be sharing the recording of this event with our social media team as well. And perfect. So I just got John's contact information, and I'll send it to the chat as well. Baroness, is there anything else that you'd like to add?
No, just thank you so much again. Hope everybody has a wonderful night.
All right, have a good night, everyone. Thanks so much.
Thanks for having us.